Hi friends, today I will talk about hypertensive crisis. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided here is for educational purpose only and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. As we know, hypertension is one of the biggest global health problems. If it is not controlled properly, it may lead to heart attack, stroke, kidney failure. So, when the blood pressure shoots up suddenly, especially when the systolic blood pressure is more than 180 and diastolic blood pressure is more than 120, we call it as a hypertensive crisis. And there are two types of hypertensive crisis. First is the hypertensive urgency, where the BP is more than 180 by 120, but there is no sign of organ damage. So it can be managed with oral drugs. The hypertensive emergency is when the blood pressure is more than 180 by 120 and there is target organ damage, for example, stroke, heart failure, pulmonary edema, AKI. Here the patient needs IV medication and immediate care. There are other terms which are used for high blood pressure are malignant hypertension. It is the old term and it is now included under hypertensive emergency. The severe BP and papilledema, that is optic disc swelling, is seen in malignant hypertension. Another term is accelerated hypertension. It is less severe than malignant hypertension. Here the patient has BP elevation with retinopathy but without papillary edema. So accelerated hypertension is high blood pressure with retinopathy without papillary edema. Malignant hypertension is severe BP with papillary edema. Coming to the pathophysiology of acute severe hypertension, what triggers the hypertensive crisis? In primary hypertensive crisis, there is an abnormal surge in sympathetic, that is adrenergic activity from the brain, which leads to increased arterial stiffness, increased systemic vascular resistance, increased cardiac output, increased venous constriction, and increased preload. And this also activates the kidney, setting off the renin-angiotensin aldosterone system, leading to more salt and water retention, and which leads to further BP elevation. How we differentiate hypertensive urgency and hypertensive emergency from the pathophysiology? In hypertensive urgency, there is sustained neurohumoral activation leading to vasoconstriction, endothelial dysfunction, altered vascular structure, but still there is no organ damage. In hypertensive emergency, a vicious cycle gets activated, causing the breakdown of autoregulation, especially in the brain and the kidney, and there occurs activation of the coagulation cascade, which leads to organ ischemia and multi-organ dysfunction. What happens at cellular level? We know that normally the vascular tone is balanced by vasodilators and vasoconstrictors. The vasodilators are nitric oxide and prostaglandin I2, and the vasoconstrictors are catecholamines, angiotensin 2, thromboxane A2, endothelin, and aldosterone. The sudden BP rise causes mechanical stress on the vessels, which leads to endothelial damage, imbalance between the vasoconstriction and the vasodilatation. The vasoconstriction dominates and which leads to upregulation of the adhesion molecules, and this marks the hypertensive urgency stage. If it is not controlled or this is continued, it becomes an emergency. And when it becomes emergency, there is activation of the coagulation cascade. The platelet aggregation occurs, which leads to thrombosis. It may progress to DIC due to platelet consumption. The patient may have thrombi blocking the small vessels, which leads to organ ischemia. There may be fibrinoid necrosis of the microvasculature. The vascular leak can occur, which leads to fluid extravasation, and tissue edema. At this point, the patient is in hypertensive emergency, and these patients needs immediate intervention. Coming to the clinical presentation and evaluation of the hypertensive crisis, the common presentation is due to target organ damage, and depending upon the organ affected, the patient may present with stroke, hypertensive encephalopathy, intracerebral or subarachnoid hemorrhage. Patient may have dissection. Patient may present with pulmonary edema, acute coronary syndrome, and in pregnant patient may have eclampsia. So when we evaluate, we must take a brief history, a thorough brief history. In history, we have to ask about the recent head trauma or injury, use of recreational drugs like cocaine, amphetamines, any recent stop in antihypertensive drugs like clonidine, beta blocker, the pregnancy status. If the patient is pregnant, we should think of preeclampsia or eclampsia. Uh, Neurological check includes confusion, agitation, visual loss, delirium, stupor, focal deficits. They are suggestive of ischemic or hemorrhagic stroke. We have to look for signs of raised intracranial pressure like headache, nausea, vomiting. The fundoscopy, if we do, we see flame-shaped hemorrhage, exudate, papilledema, and the cardiac evaluation include if the patient has chest pain, we should think of acute coronary syndrome or aortic dissection. If the patient has severe back pain, it is a classic for aortic dissection. If the patient presents with shortness of breath, it could be due to pulmonary edema. So we should just remember that the most common presentation of hypertensive crisis are neurological symptoms like stroke, encephalopathy. Patient may have cardiac symptoms like chest pain, pulmonary edema. How do we investigate the case of hypertensive emergency? We have to do routine blood investigations. We have to do ECG, conventional chest radiograph, urine analysis, serum electrolytes and serum creatinine levels, biomarkers of renal injury, cardiac biomarker if we are suspecting acute coronary syndrome, CT MRI of the brain, 2D echocardiography, and in the management, if the blood pressure is more than 180 by 120 mm of mercury without end organ damage, as we know it is hypertensive urgency, and if this VP is accompanied with end organ damage, we call it as a hypertensive emergency, and we prefer to admit the patients of all patients of hypertensive crisis for strict BP monitoring and screening for end organ damage. The four questions which treating doctors must know about these are: what is the BP level at which one should start treatment? How quickly should the BP be reduced? What is the BP target during this time period? How should this goal be achieved? And what should be the preferred drug? The two major concerns while treating the hypertensive crisis are too rapid reduction in blood pressure results in shock, too slow reduction in BP results in acute coronary syndrome and acute pulmonary edema. To say both, do not suddenly lower the blood pressure at the same time, not to take long time to lower the blood pressure. Coming to the management part of the hypertensive urgency, the goal of the blood pressure reduction is we should not reduce it too fast. In hypertensive urgency, the aim is to lower the BP slowly over hours to days, and it should not be done rapidly. The target BP reduction in first 24 hours is about 25 to 30% of the starting blood pressure. We should bring the BP down to 160 by 100 mm of mercury, and over the next few days, when the BP gets lowered, the over target should be to keep the blood pressure below 140 by 90. The oral drugs which are given for hypertensive urgency are Labetalol. We have to start with 100 to 200 milligram stat, then 200 milligram every hour as needed, and maximally we can give 1200 milligram per day. Similarly, we can give clonidine. The starting dose is zero point 0.1 to zero point 0.2 milligram stat, then 0.05 to zero point 0.1 milligram every hour, and maximum we can give 0.8 milligram per day. We can also use hydralazine. The dose is 10 to 20 milligram orally or zero point 0.3 to 0.75 milligram per kg TDS. Maximum dose recommended is 200 milligram per day. The important points which we should consider while choosing the drug, we have to see the cause of BP rise, patient's age, gender, comorbidities like CKD, heart failure. We should not use sublingual or buccal nifedipine as it can cause sudden BP drop and ischemia. So the takeaway is hypertensive urgency is not a panic situation. Manage it with oral medications and gradual BP lowering to prevent the complications. Coming to the management of the hypertensive emergency, as we know, hypertensive emergency is high BP that is more than 180 by 120 with organ damage in the form of stroke, heart attack, acute kidney injury, pulmonary edema, aortic dissection, or eclampsia, hypertensive encephalopathy. First step is we have to choose between general BP lowering approach or exception to general treatment. The exceptions to general BP lowering is seen in special conditions where we have a special BP targets. For example, stroke patients, patients with aortic dissection, patients of preeclampsia and eclampsia, in pheochromocytoma crisis, the patients if we are using IV drugs. So in hypertensive emergency, we usually use IV drugs as it gives faster results and there is well controlled BP reduction. The feature of an ideal antihypertensive IV antihypertensives should be it should act on underlying cause, it has a quick onset, it should show predictable response, it needs minimal dose adjustment, highly selective, target BP without affecting other system, does not increase the brain pressure, it has a reversible effect, low risk of hypotension or side effect, it can be easily switched to oral drugs, and it should be affordable and effective. The general treatment of the hypertensive emergency, BP targets and time frame for adults. The for adult patients without special condition, in first hour we should lower the systolic blood pressure by less than or equal to 25% of the baseline. Means the BP reduction should not be more than 25%. In the next 2 to 6 hours, our target BP should be around 160 to 100 mm of mercury, and in the next 24 to 48 hours there can be gradual reduction to normal limits, that is less than 140 by 90 mm of mercury. Just remember that we should avoid rapid correction as it may cause organ ischemia. The condition that follows the general rules are grade 3 or 4 hypertensive retinopathy. Here the preferred IV drug is Nicardipine, Fenoldopam, Nitroprusside, Labetalol, Clevidipine. In acute coronary syndrome, the preferred drug is Labetalol, Esmolol, nitroglycerin. In acute pulmonary edema, the no strict BP target timeline is there. We should focus on symptoms relief, and the preferred drugs are loop diuretic like furosemide, nitroglycerin, and nitroprusside. In acute kidney injury, the preferred drug is Fenoldopam, Nicardipine, Labetalol, nitroglycerin. So the takeaway is each hypertensive emergency has a specific treatment plan based on the affected organ, which should start with the IV drugs and follow the right target and time frame to prevent the complication. In patients of intracerebral hemorrhage, if it is acute, means hemorrhage is acute and it is of less than 6 hours from the symptom onset, that is spontaneous ICH. Here, if the systolic blood pressure is between 150 to 220 mm of mercury, the SBP should be lowered to 140 mm of mercury. If SBP is more than 220 mm of mercury, then we should lower the systolic blood pressure with close BP monitoring with the goal of 180 to 105 mm of mercury, and the MAP should not be less than 130 in next 24 hours to prevent the development of ischemic stroke. Means in the patients of intracerebral hemorrhage, if the systolic blood pressure is between 150 to 220 mm of mercury, we should lower it to around 140 mm of mercury. Okay, if the systolic blood pressure is more than 220 mm of mercury, we should lower the systolic blood pressure close to 180 by 100 mm of mercury, and the mean arterial pressure should not be reduced to less than 130 in next 24 hours to prevent the development of ischemic stroke. In patients of hypertensive encephalopathy, the signs and symptoms of hypertensive encephalopathy include headache, confusion, nausea, vomiting, and usually about after the BP is lowered. There is a dramatic improvement after BP reduction. BP should be lowered by 10 to 15 per 25% during the first hour of a treatment, and additional lowering should be gradual. The preferred drugs are the preferred drugs are acute ischemic stroke, Nicardipine for acute ischemic stroke, Nicardipine and Labetalol. For patients of intracerebral hemorrhage, we give Nicardipine, Labetalol, Esmolol. In patients with subacute hemorrhage, we give Nifedipine, Nicardipine, Labetalol, Esmolol. In patients of hypertensive encephalopathy, Nicardine, Labetalol, and Esmolol. So, intravenous nitroglycerin may be used in all of the four conditions. If, if there is exception to general treatment, the management of the hypertensive emergency will include, for example, hypertensive emergency in stroke. It is a special scenario. We have to see the type of presentation, whether it is acute ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, or patient has a hypertensive encephalopathy. The core principle is do not use drugs that increase the intracranial pressure. BP reduction should be gradual and it should be safe to avoid further brain injury. Understanding the cerebral autoregulation is very important. The brain maintains steady blood flow between the mean arterial pressure of 50 to 120 mm of mercury. Mean arterial pressure, if it is less than 50 mm of mercury, there is increased risk of ischemic stroke. If the mean arterial pressure is more than 120 mm of mercury, the risk of ICH or encephalopathy is more. So, in chronic hypertension, the brain tolerates the high blood pressures that is more than or equal to, or we can say approximately 200 mean arterial pressure better than the low blood pressure. Coming to the management of acute ischemic stroke in patient, if patient has a high BP, if the BP is less than 220 by 110 mm of mercury, and such patients should not be thrombolized, they are not fit candidate for thrombolysis. We should avoid starting antihypertensive drugs in the first 48 hours to 72 hours. If the BP is more than 220 by 110, we should gradually reduce the BP by 15% of the MAP in first 24 hours. So the preferred IV drugs are Nicardipine, Labetalol. Coming to the management of intracerebral hemorrhage, if the duration is less than 6 hours from the symptom onset, if the systolic blood pressure is between 150 to 220 mm of mercury, we should lower the blood pressure to around 140 mm of mercury. If the systolic blood pressure is more than 220 mm of mercury, we should lower the BP carefully to less than equal to 180 by 105 mm mercury over the first 24 hours, and we should ensure that the mean arterial pressure does not fall below 130 to avoid the ischemia. The preferred drugs are Nicardipine, Labetalol, and Esmolol. Coming to subarachnoid hemorrhage, the preferred drugs are Nimodipine. This is a neuroprotective drug. We can give Nicardipine, Labetalol, Esmolol in patients with hypertensive encephalopathy. Means these patients they present with headache, confusion, nausea, vomiting. They improve dramatically after the BP is lowered. The BP goal is we should lower the BP by 10 to 20%, 10 to 25% in the first hour, then reduce slowly. The preferred drug is Nicardipine, Labetalol, Esmolol. IV nitroglycerin can be used in all these cases as supportive treatment. If we summarize the drugs for acute ischemic stroke, the preferred drugs are Nicardipine, Labetalol. For intracerebral hemorrhage, the preferred drugs are Nicardipine, Labetalol, Esmolol. For subarachnoid hemorrhage, the preferred drug is Nimodipine, Nicardipine, Labetalol, Esmolol. For hypertensive encephalopathy, the preferred drug is Nicardipine, Labetalol, Esmolol, and NTG. IV nitroglycerin can be used in all cases such as a supportive treatment. In patients with acute aortic dissection, this is a true emergency. BP must be reduced rapidly. The target goal within the first hour is we have to reduce the systolic blood pressure to less than 120 mm of mercury with keeping the heart rate approximately 60 beats per minute. The preferred IV drugs are labetalol, esmolol, and we can add nitroprusside if if further BP control is needed only after the heart rate is controlled. The key points are we should lower the heart rate before or along with blood pressure to reduce the shearing stress on the aorta. In patients of the pheochromocytoma crisis, it is a rare catecholamine surge causing life-threatening condition. Here the BP spikes occurs. The patient have multi-organ damage. The classical presentation or tetrad is sudden BP rise or fluctuations or collapse, encephalopathy, hyperthermia, and multi organ failure. This is an exception to routine hypertension emergency treatment. Here we have to lower the BP to less than 140 mm of mercury in the first hour. The preferred drug is phentolamine. It is alpha blocker. It is a first line drug. We can also use Fenoldopam. It is a dopamine receptor agonist. Nicardipine, verapamil, diltiazem, and we should give benzodiazepine also for anxiety and catecholamine control. We should avoid beta blockers alone, that is propranolol, labetalol, until alpha blockade is established. Otherwise, the risk of unopposed alpha stimulation results in severe vasoconstriction and worsening crisis. So initially, we have to produce the alpha blockade first, and thereafter only we should give beta blockers. Otherwise, there will be a risk of unopposed alpha stimulation and which will further lead to vasoconstriction and worsening of the crisis. So, in aortic dissection, the first hour target of the systolic blood pressure is less than 120 mm of mercury, or we can say heart rate 60 beats per minute. The key drugs used are labetalol, esmolol, nitroprusside, and we should simultaneously reduce the heart rate along with the blood pressure. In patients of pheochromocytoma, the first target for BP reduction is less than equal to 140 mm, 40 by 90 mm of mercury. We can also use we should use phentolamine, Fenoldopam, Nicardipine, and we should never use beta blockers alone. First, we have to achieve the beta blockade sorry first we have to achieve the alpha blockade, and thereafter we should give beta blockers. In patients of preeclampsia and eclampsia and perioperative BP surge, as we know that placenta is the central trigger for high blood pressure in preeclampsia and eclampsia, initial parental antihypertensive blood pressure, if it is more than 160 by 110 mm mercury, we should think of preeclampsia, and our target should be bring the BP to less than 140 by 90 mm mercury within an hour. The definitive treatment is delivery. The first line drug, which is preferred in preeclampsia or eclampsia, or IV Labetalol, it is most commonly used, and initial dose is 20 milligram IV. If it is not controlled, we can increase the dose to 40 mmHg, then to 80 mmHg every 10 minutes. Maximum dose which can be given is 220 to 300 milligram per day. If the BP is still not controlled, we should switch over to hydralazine. IV hydralazine is a good alternative to labetalol if labetalol is ineffective or contraindicated. Oral nifedipine can be used. They are short acting. They, we should start with 10 milligram orally if the systolic blood pressure is still more than 165 mmHg. 160 mmHg. After 30 minutes of giving oral nifedipine, we can give 20 milligram thereafter, and after 30 minutes, if still the BP is high, we can give another dose of 20 mg. We have to continue 20 milligram every 4 to 6 hours if it is needed. Magnesium sulfate can be given as a prophylaxis for seizure. The loaded dose is 4 to 6 grams in 100 ml NS or D5 over 15 to 20 minutes. The maintenance dose is 2 gram per hour IV infusion. Therapeutic range is 4 to 8 milligram per deciliter. We have to monitor for magnesium toxicity also. In patients with perioperative hypertension, it usually occurs post-operatively, especially if the BP increases by more than 20% of the preoperative values. Why is it dangerous? Because it can lead to bleeding at the suture sites, cerebrovascular hemorrhage, myocardial ischemia, infarction. Sorry, once again, in patients with perioperative hypertension, as we know that perioperative hypertension usually occurs post-operatively, especially if the blood pressure increases by more than 20% of the pre-op values. It is very dangerous because bleeding can occur at suture sites. The patient may have cerebrovascular hemorrhage, myocardial ischemia, or infarction. These patients may have high mortality risk up to 50%. The preferred IV drugs are Esmolol, Nicardipine, Labetalol. For cardiac surgeries, the target blood pressure is less than 140 by 90 mm mercury within 1 hour, and we should postpone the elective surgeries if the blood pressure is more than 180 by 110 mm mercury. So, to conclude, we should identify the type of crisis. If BP is more than 180 by 120 mm mercury, we should check for the target organ damage. If the target organ damage is present, we call it as a hypertensive emergency. If target organ damage is absent, we call it as a hypertensive urgency. For hypertensive emergency, we should admit the patient in a medical ward or ICU. We have to follow the general BP lowering protocol. Special exceptions need the tailored treatment. For example, stroke, aortic dissection, preeclampsia, eclampsia, pheochromocytosis crisis. Here, we have to follow the special treatment protocols. In patients with hypertensive urgency, such patient admission may not be needed. If we admit the patient, we can use oral drugs like clonidine, hydralazine, labetalol. Here, the aim of the reduction of the blood pressure is we have to reduce the blood pressure to less than 160 by 110 mm mercury within 24 hours. Important points to be remembered are this hypertensive emergency carries high risk. It needs complex management. Higher mortality is seen. Most common cause is poor control of the chronic hypertension. So the final advice is we have to treat the chronic hypertension aggressively, prevent the hypertensive crisis, ensure better long-term outcomes. Doctors are warriors in the white coats, fighting silent battles every day. With this, I conclude my today's topic. Thank you. Keep learning.